και από το Moorfields στο Harvard. Υπέροχη βραδιά απόψε, δεν συμφωνείτε? Να καλωσορίσουμε την καθηγήτρια του Πανεπιστημίου του Harvard, την κυρία Lucia Sobrin, που θα μας μιλήσει για το Big Data Studies in Uveitis, What are we learning? Dr. Sobrin, we are very happy to have you with us tonight, and we are all ears. Thank you very much.
Thank you. It's wonderful to be with you. Thank you for the organizers for inviting me to participate in the session and to participate in the Pan-Hellenic meeting. I'm sorry I could not be there in person. This talk will be giving an update about big data studies in uveitis and what we're starting to learn from them. I do not have any financial disclosures. What is big data? Big data is data that's so large and complex that traditional data management tools are insufficient for processing and analysis. There are several examples of big data sets in medicine. One would be a large electronic medical record database. Another would be either a public or private insurer claims database. And there are also large disease registries that would fit the definition of big data. And we'll talk about how each of these has been used in ophthalmology and uveitis specifically. What are the best questions that we can ask with big data? The most important factor in answering this is the knowledge of the data set. The question that can be answered really depends on what the data set contains and what it doesn't contain. For example, there are many healthcare claims databases that contain excellent information on patient medication, how long they have been taking it, dosing, and how many times they have refilled it. And so those data sets are great for looking at medications. But there are other data sets that do not contain this information in as detailed a manner. And so it's important to first know the data points that are in each data set before deciding what questions can be asked. In general, though, in medicine and ophthalmology, the questions that have been asked of big data are evaluation of the incidence and prevalence of diseases, evaluation of real-world outcomes from treatments. There's been a lot of discovery of risk factors for disease and also some discovery of risk factor for treatment complications. And I'll talk about what we've learned in each of these areas in uveitis. Before we jump in, I'll just mention the pros and cons of big data as they will come through as we discuss the different studies. The pros are that the data sets are obviously large, and so they're good for rare diseases where it's hard in other data sets to get sufficient number of cases, and that is the case with uveitis. Most of these data sets are population-based, so there's not a lot of selection bias. They take everyone that's either in a national healthcare system or in an insurer, and so selection bias that's seen in smaller studies is not as much of an issue. And because they're often very population-based, they're very generalizable. In countries where the big data set is the entire country's insurance system, then they are very generalizable for that country. In the United States, where we're often based on private insurers' databases, then they're only generalizable, for example, to patients in the United States that are insured. There are several important cons to big data. One is misclassification bias. Determining whether or not a patient has a diagnosis really relies a lot on how the providers have coded the diagnosis. And if there's imprecision on the provider's part in coding the diagnosis, this can lead to misclassification of cases and controls. In databases where we're looking at things like visual acuity as an outcome, there's a lot of inconsistency in terms of clinical documentation, and that can make it difficult to pull data or have consistent measurement of an outcome across many patients. And on a practical level, these large data sets really required specialized data analysts who can manipulate this data effectively. I've listed here a few studies or commentaries on big data, and in particular in relation to uveitis. In some of these studies, they discuss the difficulties with ICD codes. Those are our typical diagnosis codes for uveitis when compared across electronic health record systems, and talk about the need to better define these diagnoses. So let's start with incidence and prevalence studies in uveitis. These have been done in several countries. Previously, our estimates of incidence and prevalence of uveitis have primarily been based on smaller studies that are typically regional and don't really reflect a large population. The first study listed here by Thorne et al. Was done in the Optum health claims database, which included at the time, 14 million patients in the United States. And they were able to estimate that the prevalence of non-infectious uveitis was about 121 per 100,000 for adults and 29 per 100,000 for children. And so these estimates are a little more generalizable than the previous estimates we had that were regional. Other countries have also looked at this. In Taiwan, they looked at the entire national health insurance database, which includes over 20 million patients. And they found an incidence density of 111.3 per 100,000 person years. Similarly, in Korea, they also have a national healthcare system that includes the over 55 million Korean citizens. And there, they have been able to estimate both incidence and prevalence of uveitis, which they've calculated at 10.6 per 10,000 person years for incidence and 17.3 per 10,000 person years for prevalence. These data sets also help us to look at subtypes of uveitis. And so also using the Optum healthcare claims database, there has been a study looking at incidence and prevalence specifically of infectious uveitis and scleritis. And here, the incidence is lower, at least in the United States where the study was done. When compared to non-infectious uveitis, the incidence was about 18.9 per 100,000, and the prevalence was 60.6 per 100,000. So these studies help us to really quantify the risk for these diseases in our countries. But beyond incidence and prevalence, we can also try to look at risk factors that we previously couldn't look at in smaller data sets for uveitis. One outstanding question at a time that this publication was put forth was that we knew that patients with psoriatic arthritis had an increased risk of uveitis, but there was some question as to whether psoriasis by itself increased the risk of uveitis. So again, in the same Taiwan health insurance database, they looked at incident uveitis depending on whether the patient had severe or mild psoriasis, and also if they had that in conjunction with arthritis or without arthritis. And these are the two graphs showing the primary results. And what you can see is that the greatest risk for developing a uveitis is to have psoriasis with arthritis. And in particular, if you have severe psoriasis with arthritis, you have the highest risk of developing uveitis. And the adjusted hazard ratio for that was 2.4. But even if you had severe psoriasis without arthritis, or if you had just mild psoriasis but also had arthritis, you had an increased risk of uveitis with an adjusted hazard ratio of 1.42. And interestingly, if you just had mild psoriasis, skin disease, and didn't have any arthritis, there was no statistically significant increase in your risk of uveitis compared with normal controls. These are the type of studies that are possible now with these large data sets that really were difficult to do in smaller studies. In our group, we examined vitamin D levels and the risk of non-infectious uveitis. This was done in the Optum database. At the point that we studied it, it had 60 million patients. And what we did was we took patients who had a diagnosis of non-infectious uveitis and also a vitamin D level within a year prior to their diagnosis. And we compared them to 5 matched controls without uveitis, and we matched them on various demographic and risk factor criteria. And what we found was that patients with a normal vitamin D level had a 21% lower odds of having non-infectious uveitis than patients with a low vitamin D level. This link between low vitamin D and non-infectious uveitis had been seen in smaller case control studies. And this study identifying this in a larger population lent increased support to the hypothesis that vitamin D levels may influence the risk of uveitis. And subsequent to this paper, there have been studies tracking activity of uveitis with vitamin D levels and also finding associations there. Our group has also looked at the risk of uveitis with several medications. One that was of particular interest was female hormonal therapy. We all know that non-infectious uveitis and autoimmune diseases in general are more common in women, and one hypothesis in the field has been that this is related potentially to female hormones. And we know from other diseases like lupus that female hormonal therapy can impact the number and the frequency of flares of disease. And so we decided to look at this for uveitis. We had 2 different definitions for non-infectious uveitis. One required that the patient had to have 2 diagnosis codes within 120 days. And the other one required only 1 diagnosis code, but they also had to have some kind of steroid, either topical steroid, a steroid injection, or oral steroids prescribed. In these graphs, you see for the primary definition, the patients on female hormonal therapy did not have a different risk of developing uveitis than those who had never been exposed to female hormonal therapy. However, when we took the diagnosis definition and added the requirement of a steroid to be given, we actually see that the female hormonal therapy group does have a higher risk of developing uveitis over time. From this, we concluded that exposure to female hormonal therapy does increase the rate of incident non-infectious uveitis in the case where we defined uveitis on both a diagnostic code and documentation of corticosteroid treatment. And it may be that this secondary outcome may be more sensitive at detecting non-infectious uveitis, and that the codes by themselves are a little less sensitive because they can also be used for infectious uveitis. However, it's important to note that the absolute risk increase with female hormonal therapy is modest, and it's likely safe as a therapy with regards to uveitis risk in the vast majority of patients exposed to these drugs. We have other drugs that we've investigated as well. These include statins, metformin, ACE inhibitors, and oral fluoroquinolones. We've found that metformin and statins can be protective for uveitis and have found no effect for ACE inhibitors or oral fluoroquinolones. Another area in uveitis that has been explored significantly with big data is the rate of uveitis or other ocular complications from immune checkpoint inhibitors. So this has been explored both in the Kaiser Permanente Southern California database, the American Academy of Ophthalmology's IRIS registry, which takes data from the majority of practices in ophthalmology from across the United States, as well as the Optum database. So we know that these drugs increase the risk of uveitis. The findings that have been culled from the big data studies are that, first of all, the uveitis risk with these inhibitors is specifically increased more in patients with melanoma than in patients with non-melanoma skin cancer. And this is something that probably would escape detection in smaller data sets. We're also able to examine what happens to patients who have a pre-existing history of ocular inflammation and then get these checkpoint inhibitors. And what was found is that they had up to 50% chance of recurrence of their ocular inflammation with these drugs. Because of the size of the data sets, we're also able to divide out the risk depending on which drug is given. And in this study, using the IRIS data set, what was found that the risk was that the risk for anterior uveitis was greater in patients with ipilimumab and much greater than, for example, in patients receiving pembrolizumab or in patients receiving other checkpoint inhibitors. And here you can see that the ipilimumab group has a higher rate of developing anterior uveitis. When it's given in combination with nivolumab, they still have a high rate, probably driven primarily by the ipilimumab, whereas the nivolumab and pembrolizumab ones are less, patients receiving these drugs are less likely to develop anterior uveitis. So in summary, big data studies permit well-powered investigations of risk factors for relatively uncommon disease such as uveitis. This is a field that's just beginning in uveitis. There are several future directions. One important message that's come from studies is that we need to harmonize uveitis definitions and potentially get a common data model, which means we all decide how we define uveitis in these databases most effectively. And in particular, we need to improve the differentiation of infectious versus non-infectious uveitis. The current diagnosis codes can be used by practitioners for both kinds of uveitis, and that makes it difficult to distinguish between the two. As methods become better, we expect that algorithms for defining diagnoses like uveitis will also improve. We see things like natural language processing of information in notes being able to go beyond what we get now from ITP codes. And areas that have not been explored yet are treatment patterns and outcomes for uveitis, and that is an important future direction for this field. I'd like to thank the National Institutes of Health for the grant which helped to fund the studies that we did using the Optum database. And I also like to thank my collaborators on this grant, both at the University of Pennsylvania, Brian Vanderbeek, Yingxi Xu, and Yingxi Yu, and Rebecca Hubbard, and at Mass Eye and Ear and Harvard, John Kempen, Sam Han, Gayatri Susarla, and Ashley Lee. Thank you very much.
Thank you, Dr. Sobrin. This was a very enlightening talk. We are awaiting the results of your studies. Έχουμε καμία ερώτηση για την καθηγήτρια κυρία Sobrin?